Yeah, good afternoon, everyone. Thank you very much, Mr. Chairperson. And I would like to, at the outset, thank the organizers for organizing this wonderful conference, as well as the wonderful hospitality of Bangladeshis. So I'm a surgeon from Sri Lanka, working in the southern coast of the country. Now I'm going to talk about another challenging entity for both surgical as well as medical oncologists we often see in our critical practice. So peritoneal carcinomatosis or peritoneal deposits. You might get a patient who's treated for ovarian or colorectal cancer coming to you with abdominal distension, pain, and some other constitutional symptoms. And on examination, we'd find hugely distended abdomen with something in it. So these are peritoneal deposits. So it's quite common in ovarian cancer. About 70% of patients of ovarian cancer develop peritoneal deposits during their lifetime. And even the colorectal, about 4 to 10% synchronous and 5 to 19% metachronous. But fortunately or unfortunately, these patients do not have distal meds. And systemic therapy has very limited role in these sort of patients. And they have severe symptoms because of ongoing peritoneal deposits. So they are frequently admitting in the casualties with abdominal pain, distension, and obstruction. And they are having very agonizing life because of this disease. And if you're not treated, the median survival is about 6.5 months. So we categorize them as, or regarded them as a fatal disease unless treated. So what are the options available? The first option is just leave the patient, but unfortunately this patient will have very difficult life ahead for next few months of his life. And to try some systemic chemotherapy, but as I said, there's no much benefit from systemic chemotherapy. Then surgeons can do a surgical debulking, at least to alleviate the symptoms, but it doesn't give any big overall survival. So the option available right now in our hands is called CRS and HIPEC. CRS stands for cytoreductive surgery, and HIPEC is for hypothermic intraperitoneal chemotherapy. So to understand the principle behind this treatment, I will take back to the medical school time. You know, the peritoneal cavity has a lining which is called the peritoneum, which is, and there's some kind of fluid within the peritoneal cavity. So any tumor in the abdominal cavity can shed tumor cells into the potential space. And these tumor cells can freely float around the peritoneal cavity and deposit in certain areas, especially the pelvis, sigmoid colon, paracolic gutters, and subdiaphragmatic areas, and then they produce another clump of cells. So, to understand a bit more further, if we look at to the histology of this sorry, it's an accident, I suppose. Okay. So to understand the concept of peritoneal plasma barrier. So peritoneum is lined with a little epithelium on the basement membrane, and there are lymphatics beyond that. And the vessels are, if you can see, they are quite deep. So there's a big gap between the peritoneal surface and the vessels. And this concept is called peritoneal plasma barrier. So this is the exact reason why the systemic chemotherapy or whatever the drug you give won't be able to reach the peritoneal surface where the tumor is. So this is the concept of peritoneal plasma barrier. So what is the principle of intraperitoneal chemotherapy? If you can put some chemotherapy inside the peritoneal cavity, they directly hit the target cancer cells. And as I said, because of this plasma peritoneal barrier, they wouldn't much absorb into the systemic circulation, hence the systemic toxicity is quite limited. Whatever is absorbed, go through the portal venous system to the liver and get first parts metabolized in the liver. So if there are any potential liver deposits, these cells can be killed by the fraction of absorbed chemotherapy. So this is the principle behind intraperitoneal chemotherapy. So obviously the chemo agent should be tumor targeted. For example, if patients with ovarian cancers, we go cisplatin, and mitomycin C is the preferred choice for colorectal and pseudomyxoperitoneal. And obviously they should have less systemic toxicity, even though they are not well absorbed from the peritoneal cavity, and also they should have a heat synergistic effect. So hypothermia is known to a selective cell killer for a long time. because of so many reasons. The increased temperature of hypothermia can enhance the lysosomal activities which will auto-digest the tumor cells. And it also improve the permeability of mitochondrial membrane. So, a lot of water will go inside the mitochondria, its cell, and it will die, which leads to the anaerobic respiration of the cell, which is again not very good for the cell. And also it has shown hypothermia decreases the blood supply to the tumor bed. And also it enhances the tissue permeability of chemotherapy, and it has a potential cytotoxic effect. So what is HIPEC? So it's a thermally enhanced chemotherapy. So it means we put chemotherapy which is heated inside the peritoneal cavity, which has a cytotoxic effect. So basically it's a job of a medical oncologist or a job of chemotherapy. So what's the role of the surgeon then? As you all know, surgeons are sometimes servants of medical oncologists, right? So they are to take the muck off and clean the area and give a pristine environment for medical oncologists to play. So that's the part of surgeons in this regards. So what we do is, we take all the gross tube out from the peritoneal cavity or the involved organs, take all the gross tube out, leave in pristine abdomen. Now here you can see we have taken all peritoneum out from the abdominal wall, all the pelvic organs been taken out, including the uterus, ovaries, rectum, whatever, or any tumor bearing tissues, organs are taken out by the surgeon. So that's the role of the surgeon, and the rest is done by the chemotherapy. So this concept of HIPEC and CRS has developed for last century or so. In 1930s, Meek described the cytoreduction or gross tumor reduction has a beneficial effect on the patients with ovarian cancers. And in 1979, they have first used the hypothermic heated chemotherapy in patients with pseudomyxoma peritoni and shown good results. In 1980, a famous American surgeon called Paul Sugarbaker, he has introduced this technique for GI malignancies, including colorectal and gastric. And again in 1985, he described a scoring system called PCI, Peritoneal Carcinoma Index Scorer, which reflect the severity of the peritoneal disease. And in late 1990s, he described a surgical option called peritonectomy. And he is regarded as the pioneer or the forefather of the peritoneal carcinomatosis, and he has described he has contributed a lot to this field. And ever since, it has become a fashion all over the world, and there are so many surgeons and oncologists started doing this technique, procedures, and so numerous publications came out from throughout the world, which enhances the usage of CRS and HIPEC with these patients who are suffering with peritoneal carcinomatosis. So there are some indications. I mean, this is a very big surgery, and it's called the mother of all cancer surgeries. So it's a very complicated surgery. So patient should obviously be medically very fit, and there shouldn't be unresectable distal mets. And PC score, which I'm going to describe later, should be quite limited. And these are the cancers which are really get benefited out of these procedures: colorectal, ovarian, pseudomyxoma peritoni, primary peritoneal, gastric, and mesothelioma. Now PCI is a scoring system given to identify the severity of the peritoneal disease. So abdomen is divided into 13 compartments, and 3 is given 1 to 3 is given depending on the involvement, and we give a score out of 39. Right? So if the score is very high, it means the patient is having quite severe peritoneal disease, and if the score is low, it's like Glasgow Coma Scale, which you all know. Right? And it has clearly shown the outcome is better in any patient who has either low or intermediate PCI scores, but not in patients with very high PCI scores. And what we do is, when you get a patient and we do the pre-op workout, we see what the tumor type is, and if there's any distal mets, we exclude these patients, and we assess the patient's fitness and assess the PCI score. And PCI score can assessed by either MRI or CT by an experienced radiologist, and if it is very high, then we can defer the surgery. And of course, diagnostic laparoscopy again used in most of the centers to assess PCI score. So here it shows a lot of peritoneal disease. This is the stomach, and this is subdiaphragmatic area, lot of peritoneal disease. So surgeon decides whether to proceed with the surgery or not, depending on this PCI score. And there are some contraindications if the patient is not fit enough, if the PCI score very high, or if there are distal mests which can't be resected, then of course we do not attend CRSO HIPEC. So the ultimate ambition or the goal of the surgeon is to get R0 resection, right? You can leave very little tumor behind a chemotherapy to act on, but otherwise the whole aim of the surgeon should be to take R0 resection. And also it has shown if you achieve R0 resection, the survival is much better in here. So, HIPEC is a thermal enhanced intraperitoneal chemotherapy, and complete cytoreduction surgery adds the maximum benefit if you can achieve. And literature, there were so many numerous publications came out supporting the improved overall survival. So it has been the CRS and HIPEC being the standard way of treatment for patients with this peritoneal disease. And throughout the world, so many centers, even in Bangladesh, I know there are some centers who do HIPEC. In India, so many, and even Western countries, there are so many centers. We started in Sri Lanka in 2018, and we have already done about 65 cases up to now. And so this is a little video about how the procedure been done. And we know, medical oncologists are very fond of showing the survival curves, but surgeons are quite fond of showing their work by videos. But I don't think we got enough time to do so, so I'll probably skip that because there's no much benefit for a big medical oncology audience. What I want to show is, so here, surgically what we do is we take all the diseased peritoneum out from the abdomen, including any of the involved organs, irrespective of what the organ is, right? And after that, we instill chemotherapy depending on the tumor type, and in a heated chemotherapy, and leave for about 1 hour to 1.5 hours, then drain and then close the abdomen. So this is the surgical procedure in a nutshell. So in our series, we have done about, we have assessed about 53 cases, very wide range of age, and we have done patients from throughout the country, and this is the number of cases that we have done over the years. And majority of our cancers were ovarian cancers, almost about 50%, and then followed by pseudomyxoma peritoniae coming from the appendix, and colorectal, 1 or 2 gastric, and 1 or 2 mesotheliomas. So majority of them are gynecological malignancies. And this is some important thing to identify understand the magnitude of the surgery. So these are the organs we have resected during these operations. So most of the patients had some form of colectomy, and often total proctocalectomy. In female, definitely hysterectomy and oophorectomy, and definitely cholecystectomy, which is quite common site of deposits, and sometimes splenectomy, and different levels of resection of the small bowel. So it's a very complicated surgical operation, right? And obviously, it has quite significant morbidity. And duration is the maximum we have taken about 14 hours, on average about 7.3 hours. And blood loss again, at least 1.5 liters. And we have some cases we had to transfuse about 12 units. And our success of complete cytoreduction is quite impressive. About more than 95% of the patients we have achieved R0 resection. And the problem is, these patients are very prone to get a lot of postoperative complications. Obviously, you can understand, because this surgical procedure is quite advanced or quite serious. So we had about 55% of the patients had some sort of post-op complications, and our mortality has been about 13%, which is quite high compared to the most of the published data, because this is as we started, but our mortality rates are quite improved during the course of last 4 or 5 years. And most of out of more the patients, complications had been sepsis, intraabdominal sepsis and intraabdominal bleeding, and some patients develop respiratory tract infections. And the cause of death has been the same, like intraabdominal sepsis, intraabdominal bleeding, and pneumonia. And this is our survival, and we got so many 5-year survivals, which is quite encouraging. And this is the photos. It's one of the very rare photos as a surgeon you can take. This is one of the patients whom we operated 2 years ago, young man with pseudomyxoma peritoni coming from the appendix. And we had done total proctocolectomy and with ileostomy. Now this patient then came for reversal of the ileostome. And then I opened and found that the peritoneal cavity is crystal clear. And he hadn't had a single deposit in the entire peritoneal cavity, which I think otherwise the patient would have died within about 6-7 months if he didn't do this surgery. But unfortunately, I couldn't reverse the stoma because of the adhesions. So this is something very rare photo I think a surgeon can have. And but the latest literature is actually questioning the role of CRS and HIPEC, especially on the colorectal cancers, because as the colorectal cancers tend to give more distal mets, the survival benefit is questioned. So we are in a kind of a junction whether to do CRS and HIPEC for colorectal cancers. And what are the other options available for advanced or recurrent peritonic ulceromatosis? Again, you can do surgical debulk to alleviate the symptoms. And there's another procedure called PIPEC. It's pressurized intraperitoneal aerosol chemotherapy, which is given for unresectable tumors. And the latest coming from the developed countries is called the multivisceral transplant, where they take everything out, including the pancreas, stomach, small intestine, large intestine, and do transplant, which has shown promising results, but it's very technically advanced technique, which is not actually, amicable for countries like ours. Now, this is the slide I really want all my medical oncologists to remember. And out of all the GI malignancies, the best results comes in pseudomyxoma peritoni, coming from the appendix, and mesothelioma, followed by ovarian cancers, gastric cancers, and colorectal cancer, as I said, is questionable. For some selected cases, they will get benefit out of this procedure. And in summary, peritoneal carcinomatosis has a poor prognosis if not treated, and as we all know, systemic therapy has very limited role. And for the time being, for the modern era, the option available, the standard treatment is the CRS and HIPEC, which improves the survival. And in the future, as you all talked in previous talks, it will come the personalized medicine here. So we have to identify the patients who are going to actually get benefited from this quite challenging surgical procedure and offer them only this technique, or otherwise treat the patients with other means of treatment. So it thinks that we can't run this race alone, either medical oncologist or surgical oncologist. It's all about a relay. So we have to identify where the medical oncologist can take the lead, where the surgical oncologist can take lead, especially when we are facing with challenging conditions like peritoneal carcinomatosis. So again, thank you very much for the organizers, especially Dr. Suman, who has been communicating with us and nice hospitality during the stay in Bangladesh. So thank you very much.